Hello, everyone, and welcome to the Probio Professional Discovery Academy's web seminar titled Probiotics as a Complementary Therapy for People Living with Inflammatory Bowel Disease. This is the third session of a four-part series entitled Medicine or Snake Oil? Is there a role for probiotics in your clinical practice? My name is Dragana Skokovic-Sanjic. I am a clinical pharmacist working with the Hamilton Family Health Team. And for the last many years, since 2008, I've been involved in preparing, reviewing, and coordinating publishing of the clinical guide to probiotic products available in the US and in Canada. And this is, again, one of the reasons we are now talking about it, trying to figure out how to best navigate this confusing field and assist our patients. Alliance for Education on Probiotics is supporting the clinical guide publishing. And again, with the Alliance, they're dedicated to establishing probiotics as a frontline therapy for the protection, restoration, and enhancement of human health. And again, Probio is trusted global resource for evidence-based information on probiotic products. Probio or Alliance has been compiling and reviewing and summarizing evidence on specific probiotic products and associated applications or indications since 2008. So before we ask Dr. Charabaty to start her presentation, please join us to thanking Exegi Pharma for providing an unrestricted education grant to make this enlightening four-part series education possible. We appreciate their support and thank them for bringing us together today to learn. Please remember that this event has been created for you. You are muted, but you may ask as many questions as you need through the presentation. So simply type your questions in the chat feature. That way it will be easier to make sure we follow and answer as many questions as possible. And again, this will be done at the end of Dr. Charabaty's presentation. So we are here to learn. During today's session, Dr. Aline Charabaty will review probiotics in the treatment of IBD and their role as a viable adjunct therapy, suggest how to address patient concerns, and review resources to help you evaluate and recommend probiotics. So now I'd like to introduce you to our speaker. I'm very starstruck. I'm very proud and honored to be here with Dr. Charabaty. So Dr. Aline Charabaty is the Assistant Clinical Director of the GI Division at Johns Hopkins School of Medicine and the Clinical Director of the Inflammatory Bowel Disease Center at Johns Hopkins-Sibley Memorial Hospital in Washington, D.C. So she completed her medical school at St. Joseph University in Lebanon and her internal medicine residency and GI fellowship at Georgetown University Hospital. She joined the GI faculty and established and led the IBD Center for 13 years at Georgetown before joining the Johns Hopkins School of Medicine faculty in 2019. Dr. Charabaty is an award-winning innovator. She is the co-founder of Scrubs and Heals, an initiative that is aimed at empowering women in GI to achieve successful and fulfilling career in medicine while integrating work and life. We all need to learn about it. So she is also a founder of At Monday Night IBD, a Twitter forum that brings clinicians together to discuss the management of complex IBD cases. Dr. Charabaty has numerous peer-reviewed publications and is actively involved in educational and advocacy activities with national and international GI societies. She is the associate editor for CC360, an online journal, and sits on the editorial board of Gastro and Endo News. Now that you have been introduced to our speaker, let's start learning. Welcome, Dr. Charabaty.
Good morning, everyone. I hope I'm unmuted. Am I? I'm not sure anymore.
We can hear you, we can see you.
Perfect. All right. Well, Dragana, thank you for this fantastic introduction. And thank you for inviting me to this fantastic series on the role of probiotic in many of the GI illnesses. It's really my pleasure to spend the lunchtime with you all. Thank you for all joining us today, and I'm looking forward to the Q&A sessions and to hear your thoughts and your experience using probiotic in inflammatory bowel disease. All right, so what we're going to do this today is briefly go over what is inflammatory bowel disease, Crohn's, and ulcerative colitis. When do we talk about pouchitis? And what's going on in terms of the gut microbiome and IBD, and how can probiotic fit in as an adjunct therapy in inflammatory bowel disease? So inflammatory bowel disease, like most of you know, are basically two types, ulcerative colitis and Crohn's disease. We differentiate them by the location of the inflammation, the behavior of the disease, the appearance on endoscopy, and clinical symptoms. So with ulcerative colitis, the rectum is always involved, and sometimes, the inflammation can extend proximally to involve part of the colon or the entire colon. But the inflammation in ulcerative colitis is continuous, like this diagram is showing you in red. So whatever part of the colon is involved, it's a continuous inflammation, and it's a superficial inflammation, means it only involves the superficial layer of the gut, mucosa and submucosa. With Crohn's disease, it's different. In Crohn's disease, any part of the GI tract can be affected, not just the colon. It can be the upper GI tract, the small bowel, the colon. Most common sites of inflammation is the colon and the last part of the small bowel, the terminal ileum. And we talk more about a patchy inflammation. There are areas that are diseased and some areas that are normal. But here the inflammation goes deeper. We talk about transmural inflammation, meaning that it's an inflammation involving the entire wall of the gut. And that is why with Crohn's disease we can have complications such as strictures and perforation and abscess and fistulas. So the typical natural history of inflammatory bowel disease, whether it's UC or Crohn's, is that of flares and remission if we don't do anything. And the goal of the therapy is to put our patient in remission and maintain this remission. So we want our patient to feel well and to continue to feel well. But beyond that, we actually want their colon or their small bowel inflammation to be controlled, and in order to prevent further flare and complication from the disease. So when we talk about remission, it's important to remember we're talking about clinical remission, meaning symptoms under control, but also we aim for endoscopic remission, meaning we want the inflammation to be under control, because that is what's going to prevent further flare-ups and complications. Of course, with inflammatory bowel disease, the inflammation is not limited to the gut, and often patients have what we call extraintestinal manifestation, mainly joint disease, but also patients can have skin disorders, liver disease, etc. So if your bowel is inflamed, you've seen some of these endoscopy picture, and I apologize if I'm sharing with you these images during lunch hour. For a GI, it's heaven to spend lunch looking at endoscopy picture, but I understand it's not the cup of tea for everyone. But when you have inflammation on the gut, as you can imagine, you're going to have abdominal pain, diarrhea, blood in the stool, urgency, having to run to the bathroom constantly, even if it's just for a little bit of stool, a little bit of blood or mucus, and incontinence. With Crohn's disease, we talk that we can have more of complications such as strictures and abscess, but also patients often feel poorly overall with fever, weight loss, failure to thrive, fatigue. But I think, at any time we're talking about inflammatory bowel disease, in addition to the GI symptoms, we always need to remember that patients, that this disease really affects patients at many levels of their lives. And in addition to the GI symptom, and in part because of the GI symptoms, the quality of life is decreased. There's a big psychosocial burden, family life, sexual life, financial health, everything is disrupted. So it's important to keep that in context. That is why we are looking for different ways and different combination therapies when we are approaching our patients with IBD, because this is a disease that affects their GI tract, but also their overall quality of life. And whatever we can do to improve symptoms and quality of life, that is important to do. So what is the extent of the problem? So depending on what studies and what questionnaires you use, we have around 1.6 to 3 million people in the US affected with inflammatory bowel disease. But what is even more concerning is that the incidence of inflammatory bowel disease is increasing in this country and all around the world. And in this country, we're seeing an increase in the incidence, new cases of inflammatory bowel disease in the typical population where we think IBD exists, Caucasian and people of Jewish descent. but we are also seeing a huge increase in the incidence of IBD in minorities and in immigrants. And this is really kind of a disease of this next century. And something is happening that the incidence of IBD is increasing even in a population where we didn't used to see inflammatory bowel disease. And we see that throughout the world. So in areas like, China, Brazil, Middle East, where IBD was almost non-existent, we're seeing an increase in the incidence of new cases. The typical age where it starts is in young people, and this is a chronic disease, so it starts in the young and carries during their years of life. So again, highlighting the importance of controlling this disease to allow a good and healthy life. But also we see a second peak after age 50, and also we're seeing an increase in the incidence of new onset inflammatory bowel disease in the older population. It's very important to remember that most patients with IBD do not have a family history. So not having a family history does not exclude the diagnosis. Only 5 to 10% of people will have a family history, really highlighting that genetics play an important part, but it's not all part of the same story. So one of the first questions I get, and I think is relevant to this talk, is why do people develop IBD? That's one of the first questions my patients ask me. And I put up this infographic that actually we used in a book chapter that I published with a couple of fellows and residents. They did a fantastic job putting this imagery together. But it's just really to show that we have more and more of a sense of why people develop IBD, but all these factors really interact and influence each other. There are probably genetic factors, but that's not the only thing. And some of these genetic factors probably determine how our gut responds to environmental factor, how the intestinal barrier is working, how functional or dysfunctional the gut immune system is, and determine a part of the microbiome. But what I'm trying to show here is that environmental factors are also going to affect the gut microbiome and the intestinal barrier. The microbiome and the intestinal barrier really talk to each other, and one influence the others. So if we look at this, the factors we probably can work on are the environmental factor and the microbiome, right? So these are the things that we can do or our patients can do to help kind of maybe either decrease the severity of the IBD or control the IBD. In terms of environmental factors, what we know affect the risk of IBD is smoking in Crohn's disease, antibiotics. Several studies have shown that multiple use of antibiotic in childhood or in adult increase the incidence of inflammatory bowel disease. And we're finally starting to see data on diet. And recently, this is the Pure study that was presented at DDW, showed that eating processed food increase the risk of developing inflammatory bowel disease. We follow the population for 3 years, and the more processed food was in the diet, the higher the risk of developing IBD. And by processed food, we mean added sugar, processed meat, everything coming in a package, in a box. This is processed. So here you go. So let's talk more about the gut microbiome. What do we mean by that? Well, it means a collection of bacteria, fungi, viruses all in our gut. If you measure, if you want to weigh them, it's up to 2 kilograms, so around 4 pounds of bacteria living in our gut. There are 23,000 human genes in our body versus 3.3 million of microbial genes. So in some way, we're more bacteria, more microorganism than we are human cells. So it's very important to realize that this microbiome is probably, and we're seeing in the scientific data, playing a huge role in our gut health, but also in the health of our entire body. And so it's important to remember that we need to be respectful of this gut microbiome and think about ways to make it a healthy microbiome. All right. So what does this microbiome do? Well, they do a lot of things, but for the purpose of this talk, they help with food digestion and with the degradation of fiber. They produce short-chain fatty acid, and you'll see that later in my talk. And short-chain fatty acid are really important in maintaining the gut barrier integrity. When we talk about the gut barrier integrity, meaning that lining of the mucosa, that epithelial lining of the gut, we need to be strong enough to fend off bad things, bacteria, toxin, and we needed to be smart enough to let the good nutrients in. So the integrity of the gut barrier is very important. It actually controls intestinal cell growth. It protects against pathogen. It trains our gut immune system in recognizing what's good, what's bad. And always important to remember that actually the gut is the largest immune organ in our body. 70% of immune cells are in the gut. So obviously this interaction between the microbiome and the gut immune system plays an important role in inflammatory process, and it can influence distant organ and disease process. So what's going on in a gut microbiome in our patients with IBD? Well, we see dysbiosis, meaning there's an alteration of the composition of the gut microbiome, but also a decrease in the diversity. Like everything in life, the more diversity we have, the better. And our gut microbiome thrive on diversity and a balance of bacteria that are beneficial and maybe less beneficial. In patients with IBD, we see more of the pro-inflammatory organism and less of the anti-inflammatory organism, and their function has changed and the diversity of the gut microbiome has changed. So why do we have this? And we'll talk a little bit more also about this later, but our genetics don't change over a generation. What has changed is our lifestyle, the way we eat, the way we behave, our physical activity, etc. And this is a little bit to highlight maybe the good and the bad on one side of the screen and on the other. One is, I grew up playing outside, playing in the dirt. We didn't think much about washing our hands or not putting things in our mouth. And that is a healthy way of living. We know from data that kids that grow up in, closer to nature, kids growing up in farms, kids that have pets, actually their microbiome is healthier, stronger, more diverse, and they have a decreased risk of developing inflammatory bowel disease. We live in an environment that's super hygienic now, and we already talked about the role of antibiotic, but probably also, being super clean helped us with preventing a lot of infectious disease, but also kind of sterilized a little bit of gut microbiome. It changes composition. Physical activity, right? So playing outside has been replaced by sitting in front of video games and screens all day, and that physical activity also has an effect on our gut microbiome. What we're eating, right? So simple foods, little meat, because meat has always been hard to find and more expensive. And in a lot of traditional cooking, you have more of fruits and vegetables and grains and legumes. And this has been really replaced by more of the fast food. Easier, cheaper to get, but also it's changed our gut microbiome. Added sugar, same thing. But even when you want to try to eat healthy, it's becoming more tricky. I put a picture of a chicken, an adult chicken in the 50s. Look how skinny and sickly looking, but it was a healthy chicken, and this is how it looked back in the 50s. And now look at what a baby chicken looked like, right? Much bigger, much plumpier. Between growth hormone and antibiotic and everything we're giving our chicken and other, other animals that we're consuming, all this is affecting what's happening in our gut. So can part of the solution in inflammatory bowel disease to replace the lost organism, to kind of enrich our gut microbiome with what's been lost. And since we know that gut microbiome are involved in the IBD pathogenesis. So far, the main focus on treating inflammatory bowel disease has been targeting the immune system. How can we block the inflammatory pathway? How can we block some of the immune pathways leading to inflammation? So that has been the mainstay of therapy, and they work well, but they don't work in everybody, but they work well. But how about if we change the microbiome and make it better? So I want to spend the next few slides really talking about which patient population we're thinking about here. And most of the study looking at probiotic in addition to conventional therapy, where we see success, have been in ulcerative colitis. And Crohn's disease, we don't see much of success there. So I'm going to focus on ulcerative colitis. And when we look at ulcerative colitis, not all UCs are the same, right? We have different degree of severity of the disease based on symptoms, how many bowel movement, how much blood we're having, is this causing anemia, on inflammatory markers, and also on how things look on endoscopy. How severe is the inflammation on endoscopy? And in all the studies looking at probiotic in ulcerative colitis, we're really talking about mild to moderate disease. So patients kind of in that type of inflammation. And again, these are some of the endoscopy pictures showing you, on top is a normal colon, looking pink and pretty, and you see the nice vessels. When then after this, we have a mild ulcerative colitis. It looks more granular, like somebody put sandpaper on the colon and took away that, a smoother texture. And then we have more severe disease, more, erythema, more redness, more inflammation. And then very severe disease, we have ulceration, very friable mucosa, bleeding, just to the touch. So when we're talking about using probiotic, we're really talking about patients with more mild to moderate disease. So what is the current therapy of an ulcerative colitis? And I want us to focus on the left screen. So for patient with mild to moderate ulcerative colitis, or patient that we think, we can treat them, they are low risk of losing their colon because of severe disease, the mainstay of treatment has been mesalamine. And what mesalamine are kind of a topical therapy. So when you take those pills, they open up in the gut and act like an anti-inflammatory cream to the gut. And so mesalamine have been the mainstay. We can induce remission by using steroid, prednisone, or budesonide, and then maintain remission by using mesalamine. Patient with more severe disease, this is when biologic come in play, but also immunomodulator. And most of the studies, again, looking at probiotic in UC are in mild to moderate UC, patients on mesalamine. Some patients, in some study, they include a patient on immunomodulator, but we don't have study of probiotic in addition to biologic in patient with moderate to severe disease. So something important to keep in mind when we're talking about probiotics. So what is the data that we have? So again, I said this, we look at UC with conventional therapy, on mesalamine or immunomodulator, but patients who continue to have symptom with the UC disease activity index score around between 3 and 9, so mild to moderate disease. And the studies that we have showing efficacy of probiotic use a decimone formulation. It's a mixture of different organisms and high concentration. And the endpoint of this study was a decrease by 50% of the UC disease activity score index. So we want to see a decrease in the number of bowel movement and bleeding and the discomfort and the urgency by at least 50%. In the study by Sood and a colleague, they used 3.6 grams twice a day. And what they see is quite impressive improvement very early on. Within the first 6 weeks, so at 6 weeks, 32% of patients on the decimone formulation had response to adding, the probiotic versus 7% of placebo. Again, keep in mind, placebo is not purely placebo. These patients were on mesalamine or immunomodulator. So being on conventional therapy plus the decimone formulation improved symptoms in 32% of patients versus being on conventional therapy alone. At the end of 6 weeks, most patients didn't have any improvement. And at week 12, so 3 months later, 43% of patients on the decimone formulation in addition to conventional treatment had improved versus 16% on conventional treatment alone. So these results are very encouraging. And the way I use it in my practice, if somebody's doing well on mesalamine or immunomodulator, but not completely well, or the disease is not severe enough to justify jumping to a biologic right away, this is a perfect adjunct that I know is going to be beneficial to the patient in achieving clinical remission. I wanted to mention this meta-analysis that looked at all the studies done using the decimone formulation, and most of the study used 3.6 grams per day. And again, 44% of patients on this formulation had improvement of their UC disease activity index score versus only 25% on placebo. So very encouraging data here on this formulation. We're going to shift gear and talk about pouchitis. What is a pouch, first of all? In our patient with ulcerative colitis that is refractory to treatment, not responding to treatment, or patients who develop severe complication like tremendous bleeding or cancer in the context of colitis, the treatment is to remove the entire colon, and we bring the small bowel and make a loop in a J shape. That's why it's called a J pouch. And we suture these two loops. So it's a little bit like if you have 2 rooms in your house and you break that wall between the 2 rooms, making a bigger room. Because the small bowel caliber is narrow. If we connect that small bowel straight to the anus, our patients are going to the bathroom all the time. So by creating this pouch, we're creating a reservoir so that our patients are able to hold their stool and go have a bowel movement. The frequency of their bowel movement is reasonable. So this is what a J pouch means. And a pouchitis is an inflammation of that J pouch. On endoscopy, we see the same thing we kind of see with UC. So the lining, the mucosa is edematous, granular, friable. We can see ulceration. Patient have increase in the number of bowel movement. Their bowel movement are looser. They can have cramping and abdominal discomfort. Sometimes patients will have blood in the stool. Fever in severe cases, urgency having to run to the bathroom. And unfortunately, this is a common problem. Within the first year of the surgery, a quarter of the patient will develop pouchitis. And over time, the risk of developing pouchitis increase over time. And some patients have it multiple times in the course of their life. So why do we have pouchitis? And that's a very interesting question. So one of the things is that, that small bowel, which is not made to have stool sitting there, right, for a period of time. Now we have fecal stasis, we have stool sitting there with the bacteria of the stool, etc., maybe causing dysfunction of the immune of the mucosa, the gut barrier, the immune system of the pouch, and creating promoting development of pouchitis. We know there's a genetic susceptibility also. We know, for example, that patients who have ulcerative colitis and PSC, that's a kind of a different category of UC patient, have a higher risk of developing pouchitis. So there's a genetic component, that the fact that stool is sitting there, there's a change in the type of bacteria that the small bowel is exposed to. But also there is probably dysbiosis that is seen because patients have inflammatory bowel disease. And the reason we say that is that pouch can be made for patient for other conditions such as FAP, familial adenomatous polyposis. These are patients that have multiple polyps in the colon. They have high risk of developing colon cancer at a young age. So the treatment is to remove the colon and make a pouch. And in these patients, we do not see as much pouchitis than in patients who had a pouch because of inflammatory bowel disease. In patients with FAP, we see pouchitis rarely. It's usually very mild, well controlled. It usually happens after many years of disease, versus in our IBD population, it happens early, it tends to recur, etc. So there's definitely dysbiosis that is promoting pouchitis in our patients with inflammatory bowel disease. And this study is very interesting because it showed that having dysbiosis before colectomy in patients with UC can predict their risk of developing pouchitis after having the surgery. So that is, because of predisposing factor there. This is another interesting study looking at the gut microbiome in patients with UC and a pouch. So they had a colectomy, they have a pouch and develop pouchitis. In patients with UC who have a healthy pouch, and in patients with FAP who have a pouch. So non-IBD reason to have a pouch. And the bacterial diversity was greater in patients who have a pouch because of FAP compared to patients with ulcerative colitis, whether or not they had pouchitis. So the bacterial diversity in the pouch is protective against pouchitis. Hence, again, keep that in mind when we start talking about probiotic and pouchitis. So what is the typical treatment of pouchitis? It is, can everybody hear me okay? All right. So the typical treatment of pouchitis is antibiotic, metronidazole and ciprofloxacin most of the time. And 80% of patients will go in remission after one antibiotic course, but up to 60% will have recurrence of pouchitis. And we talk about relapsing pouchitis when patients have more than 3 episodes per year, chronic pouchitis when it lasts more than 4 weeks despite antibiotic use. And some patients, if we stop the antibiotic, the symptoms come back. That's why we talk about antibiotic-dependent pouchitis. And in some patients, despite using antibiotic, the symptoms do not get better. That's when we talk about antibiotic refractory pouchitis. So our treatment with antibiotic is not perfect. There's recurrence, there's relapsing, and there are patients that are antibiotic refractory. So, so how can we use probiotic here? All right. So there's obviously a need to do something better and more for our patient with pouchitis. And the study is looking at probiotic use with a decimal formulation in patient with pouchitis. They all looked at the maintenance of remission once it's been induced by antibiotics. So patients with pouchitis were given antibiotic. Once the pouchitis symptoms resolved, they were started on the decimal formulation. And again, here the results are very encouraging. In a study by Jonchetti, looking at relapse rate at 9 months, only 15% of patients taking the decimal formulation had a relapse of their pouchitis versus 100% of those in placebo group. And what was interesting, we looked at the gut microbiome in patients receiving the decimal formulation, we see that the fecal concentration of the good bacteria was increased from baseline when patients were given the probiotic. In another study by Mimura, again, similar result, 15% relapse if they were using probiotics alone versus 94% in the placebo group. And finally, in Beauchene study, at 8 months, we see that 6 out of 31 patients stayed on the probiotic, 23 stopped because of relapse, and 2 stopped because of adverse effect. And we talk about that, what that means. Adverse effect, actually, let's talk about this now. Probiotic can cause more bloating symptoms, cramping, diarrhea. So if you're on a probiotic and you have these kind of symptoms, it's important to be aware that sometimes probiotic are not well tolerated. So this is again the Jonchetti data showing how being on the probiotic formulation, the decimal formulation, previously known as VSL number 3, patients maintained remission versus those that were on placebo, they relapsed. And they relapsed very quickly. Within 4 months, these patients had recurrence of their probiotics. So that is very powerful data here that can really give a good solution for our patient with recurrent pouchitis. How about if we can start from the beginning? So how about if we don't wait until we have pouchitis to start using probiotic? How about if we started right after surgery? So patients with UC get a colectomy, get a pouch, and we start the decimal formulation right after surgery. And here again, we see that using this formulation can prevent the development of pouchitis. Only 10% of patients on the decimal formulation develop pouchitis in the first year of using it versus 40% of patients on placebo. So if after surgery you were not started on a probiotic, you have 40% risk of developing pouchitis within that year versus if you were started on the decimal formulation, the risk of developing pouchitis within a year was only 10%. Again, very encouraging data on using this type of probiotic in our patient with pouch. So I want to conclude with a few slides that really kind of, where I share with you my philosophy of how to approach things. And, I showed you data, evidence-based data on the use of probiotics in mild to moderate UC on conventional therapy and in pouchitis, either as a prevention to develop pouchitis or to maintain remission after a course of antibiotic. But I think that what's important to keep in mind is that, like everything in life, a solution is not just a pill, and it's not a quick solution. I think those quick solutions can get us into trouble, and it's important to look at probiotic as one component of working toward a healthier and more diverse microbiome. So I always try to think that my grandmother was always right, because she always said, watch what you eat, exercise, and have good night's sleep, which are things that we don't do well when you go to med school. But I think all of us are a little bit guilty of not doing great. But all we can do is our best, and it's important to understand the data behind that. So we are what we eat. And it's important to realize that different type of diet will stimulate different type of organism, but also not just the organism, but also what kind of genes the organism are expressing. What is the behavior of this organism? So when we're talking about microbiome, it's so important to remember it's not just what type of bacteria or virus or fungus we have, but also what are they doing? What is their function? And we see that the vegetarian diet, the Mediterranean diet promotes certain type of bacteria, but the Western diet, where we have more carbs and sugar and fast food, etc., very little fiber, very little fruits and vegetables, promote more of the pro-inflammatory bacteria. And it's very important to know that these changes happen very quickly. There was a study published last year looking at people immigrating from Thailand and looking at the microbiome when they arrived to the United States. And very, very quickly, within a few months, the gut microbiome lost in diversity and their function changed. And people lost their the enzyme that is involved in digesting the fiber of the vegetables. So something about going from a non-westernized world to the U.S., including diet and lifestyle, change the gut microbiome very quickly. So that shift is done very quickly, and the shift back is also done very quickly. So it's important to keep that in mind when you're thinking about changing your diet. And also, it's important to keep in mind, probiotics that are present in food source, typically fermented food. And I'm a big fan of yogurt, mainly of homemade yogurt, because homemade yogurt you have to allow to ferment for 24 hours. This make it really rich in the good stuff, versus store-bought yogurt. The fermentation time is less because it's an industry. But pick the fermented food that you enjoy, and incorporate it in your diet. And again, something I always tell people: don't think of it as medication. Pick something that is, pleasant to you, that you can, eating something going, I don't like this, but I have to take it because it's good for me. I don't think it helps. I think pick what the fermented food that you enjoy, and think about prebiotic. What prebiotic are? These are the non-digestible fibers that we eat, and they get fermented by the bacteria, and that produce again those famous and much wanted short chain fatty acid that have an immunomodulatory effect on our gut. They really regulate our gut immune system. They alter the microbiome composition and function, and they're the good stuff for us. So 25 to 40 grams of fiber per day from different type of food can really be useful. Again, keeping in mind that I know for many patients with inflammatory bowel disease, some of these carbs, the legumes and the beans and some fruits and vegetables are difficult to digest and can cause discomfort or worsening of symptoms, or even like IBS type of symptoms with gas and bloating, etc. So it's important to incorporate these foods in a form that you tolerate, whether it's very well cooked, whether it's blended, pureed in a soup, in a smoothie, or and choose the food that you can tolerate. Those prebiotic food that are going to help nurture the good bacteria in our gut. Good bugs like a good workout, like everybody else. So this is we looked at this is a study that looked at adults that are sedentary. Some were lean, some were obese, and these adults were started on some endurance training on a regular basis. And very quickly we see a change in the bacterial composition and the gene expression, and increase in the short chain fatty acid that are good for us in both lean and obese patient, more so in the lean adult. And this was independent of the diet. But this also occurred as long as people were exercising. When people stop exercising, everything reversed back to the original microbiome. So pick a physical activity that you tolerate, that you enjoy. Listen to your body, do something that's pleasant for you. But a regular physical activity is affecting our gut microbiome. And finally, a good night's sleep that will keep your doctor away. We have the GI tract actually works on a circadian rhythm. So we have to be respectful of that. And losing night of sleeps and not sleeping well or having poor sleep can really affect the gut microbiome. Again, I'm mindful that many patients with inflammatory bowel disease have to get up at night or don't sleep well because of their GI symptoms. But again, controlling the disease, figuring out how we can get a better sleep hygiene, really promote an increase in the good in the good bacteria and a decrease in pro-inflammatory cytokine. So I'm going to wrap it up by saying that probiotics have very encouraging and good data as adjunct therapy in patients with mild to moderate UC, and as therapy in patients with pouchitis. But also it's important to treat our gut bacteria well by other ways: eating clean, avoiding added sugar and processed food, favoring natural ingredients, having a good amount of fiber in the form that you tolerate, find a physical activity that you enjoy, have a good night's sleep, and live a little bit dirty. So I know we're all using antibacterial now that and soap because of COVID pandemic, but if possible, avoid antibiotic when they're not necessary. Avoid antibacterial soap if you're at home and in a safe environment. Spend time in nature, get dirty in nature, and enjoy yourself. In terms of practical pearls on how to use probiotic, choose your probiotic wisely. Choose the one that has been studied. Not all probiotic are created equal. So choose the probiotic that have been studied, where we have evidence-based data that it works for the condition that you're trying to treat. For inflammatory bowel disease, probiotics are effective in mild UC in addition to conventional therapy, and in pouchitis after inducing remission with antibiotic or as a preventive measure. Um, Communicate. So physician ask, and clinician and pharmacist ask your patient what they're on, what if they're taking probiotic, and patient tell your medical team that you're taking probiotic, because sometimes your symptoms of bloating and diarrhea could be due to the probiotic, or sometimes you're spending your money on the wrong probiotic for what you're trying to treat. So it's important to let the medical team know. And probiotic again are one of the lifestyle change that aim at regaining and maintaining a healthy gut microbiome, and use trusted resource like what we're doing today, right? So this is the website for usprobioticguide.com, and for Canada it's probioticchart.ca. So use trusted resources that are constantly curating the medical literature to find what is the right probiotic for the right condition that you're trying to treat. So I'm going to stop here and give back control of the screen, and I'm looking forward to your questions.
Thank you, Dr. Charabaty. It was excellent and very fast, and I hope everybody could hear you. I know that some people were mentioning that they had issue with the volume, but we will have this session recorded, and you can go back and listen to it again. So we have lots of questions, and now monitoring chat and Q&A, so I'll try to go back and forth. So one of the first questions is, were there any side effects reported in meta-analysis of probiotic VSL number 3 in UC patients? Any concerns about using in patients who have altered bowel from surgery and are at risk of SIBO, keeping in mind side effects of bloating reported in some patients with probiotic use?
All right, well, this is a great question, and I try to touch upon this during my talk, is that, probiotics are not for everyone. I have many patients that come to me and they say, I tried this probiotic and I felt worse, and that's okay. It's important to realize that when we're using a probiotic, I showed you data, there's a percentage of patient overall, a higher percentage of patients do better on a probiotic than if they don't take probiotic, but it doesn't mean it's for everyone. And this is true for any therapy that we have for inflammatory bowel disease or other GI condition. There's not one therapy that works for everyone. Even when we talk about biologic therapy and immunomodulator or Misami, they don't work for everyone, right? So and for some have more side effects than others. So it's important to really listen to how your body is responding to the probiotic. That's one. Two, like I said, use the probiotic that's been studied. But, if you experiment and you feel that other probiotic of high quality, some of the probiotic recommended by trusted resource work better for you, that's okay. Because it's important to remember that we don't have at this point a way to measure what is your microbiome doing. I know there are tests out there that give you a list of different bacteria or fungi that you have, but I showed you we have trillions, right, of organisms. So we're not testing for all these. And more importantly, of what kind of organism you have, what's more important is what is it functioning, what are they doing, what gene they're expressing. And we don't have a way to test for that now. So when we're recommending a probiotic, we're recommending based on data that this is, something that is very likely to improve your symptoms, but it's not customized or personalized to your current gut microbiome and what your specific needs are. So sometimes this probiotic might not work for you. You might have, side effects of bloating, diarrhea, etc. Now, if you have, you talked about SIBO, small intestinal bacterial overgrowth. So the way we approach SIBO is a little bit, similar to the way we approach pouchitis, right? So one of the treatment is antibiotic, and the goal of the antibiotic is to reduce those excessive bacteria that are causing symptoms. And another approach is probiotic, which is to give you the good bacteria, hopefully overcome the bad ones that are causing symptoms. But often, honestly, it's kind of a combination, right? So using an antibiotic to calm things down, followed by probiotic, lifestyle changes that will kind of nurture a healthier gut microbiome. So I hope this answers your questions.
There are lots of questions about Visbiome versus VSL number 3, what strains are in VSL number 3, where the Decimone formulation can be obtained. And if I can just jump in, the Decimone formulation that's been around for many, many years was sold as VSL number 3, I believe, until 2017 or so. Now it's sold as Visbiome. In Canada, for example, VSL number 3 is no longer available. Visbiome is. US has original formulation, which is Visbiome, and the VSL number 3 has different formula. So that's kind of a bit of confusing. And I think this is why there's lots of questions about it. There's also another question and asking about recommendation for 12-year-old recently diagnosed with Crohn's and recurrent C. diff and been on vancomycin taper for approximately 6 months, tried VSL and Florastor, but caused diarrhea. Kids cultural tolerated well, takes 2 doses per day, drinks small yogurt smoothie daily too, and vancomycin ends in 8 days. It's very kind of individual question, but very common, right?
Yeah, I mean, and this is, I'm glad this question was up there and this like a real life example, right? That we were talking about. If something doesn't work for you and other high quality probiotic work better, that's the one that you should stick with, right? And it seems that you're also incorporating lifestyle changes, the yogurt and different things. And I know it's difficult to kind of sometimes differentiate as Crohn's symptoms, as C. diff symptoms, when everything is happening at the same time. And I'm sorry this is happening to a young boy, but it sounds like he's on the track of remission and you're doing the right thing. You found the probiotic that is helping him, that is not causing side effect, and you're changing, you're adding, if you want, pro and prebiotic in his diet. And I think that's the right way to go. And it's a great example to illustrate, how we use data, but then also we have to listen to how we're responding to a specific medication or probiotic or supplemental medicine that we're using. So, and I'm just going to follow because somebody asked, when do you tell your patient to expect results for probiotics? So in the data that I showed you, like kind of the endpoints that we looked at was at the end of 6 weeks, at the end of 12 weeks. So that's what the range I give my patient, right? For any therapy that we have, I usually say you should see some improvement after a couple of weeks, but the full effect will be in 3 months. And that is true for prescription drugs for IBD, but it's also true for probiotics. So I think it's important to be patient, but also if you've been on something for 6 months and it's not working for you, it means it's not going to work. So I tell people in the next few weeks you should feel better, but we'll see the full effect after 12 weeks. And if after 12 weeks we don't see improvement, then we should move to something else.
There are also lots of questions about looking at mild and moderate UC and pouchitis prevention, but compared to the maintenance, how about the Crohn's disease? I think this was something that you mentioned at the beginning, but maybe just can repeat for the people that logged in later, the lack of evidence for people in probiotics for Crohn's disease.
Yeah, so Crohn's disease have been, it's been more difficult to study if you want, or to get good results from microbiome manipulation, anywhere from fecal transplant to probiotics, right? So we have some data on fecal transplant in UC, we have data on probiotic in UC, but in Crohn's disease, we're not seeing as good of a result. So fecal transplant probiotic haven't been used in Crohn's because the study don't show promising results. But it could also be because Crohn's is more heterogeneous than you see. Like I said, it can affect different part of the gut, small bowel, colon, different part of the colon, small bowel and colon, etc. And maybe in the studies that we have, we're putting all Crohn's together, and they're probably not all the same, and probably not all affected similarly by the gut microbiome. So for a patient with Crohn's disease, I typically do not recommend probiotic. Having said that, sometimes patient with Crohn's disease can also have irritable bowel syndrome symptoms, right? And that can benefit. They can benefit from specific probiotic. Or some of my patients who have some strictures that promote small bowel bacterial overgrowth or SIBO and have symptoms from that, they can benefit from probiotics. So it's important to see things not black and white, but for the disease itself, we have not seen probiotic as adding a benefit. But as a patient with Crohn's disease, you might benefit from probiotic for some of the IBS symptom or bacterial overgrowth, etc.
Lots of questions about coverage for the Visbiome or VSL number 3, formerly known as. I can tell you that in Canada, it is over the counter in US as well. But in Canada, we had luck with some GIs writing letters to the private insurance to have it covered. I'm not sure what is your experience in US with the coverage for these things, because again, they are available without prescription.
Well, Canada always does it better, that's for sure. The maple syrup is better. The fall is better. For what I've done for my patient, different things. One is sometimes when I write it as a prescription, it's covered. When I write it as a double strength, it seemed to be covered more than you know the regular strength. Writing letter that this is part of the treatment can sometimes get it covered, and sometimes patient, if it's not covered by insurance and I write a prescription for it, it can be covered under their flexible health account. So this is when people put money on the side from their, out of their paycheck to cover extra medical expenses, and if they show that they have a prescription for the probiotic, it can be covered by that flexible plan.
There are a few questions about diet, but before that, there's a question about taking, should we take Saccharomyces boulardii in addition to Visbiome? I'm not sure you can answer, but let me just jump in. It's almost like Dr. Charabaty is doing her scope in a clinic, and then you add me there just because I know what I'm doing. I don't know what I'm doing with the scope. So combining two good strains or two good products without evidence they work well together, it's probably not a good idea. So Dr. Charabaty, what is your take on it?
So I'm more of the person like, let's see what's working, and if it's not working, go to the next one, because I think when you throw everything in the sink, then you don't know what's working, what's not working. You don't know if you're having side effect to one or the other. So I think it's important in the probiotic, for probiotic, is really kind of to experiment and see what works best for you. And if it ends up being that using two different probiotic work better for you, that's fine. I typically don't recommend it because I feel like, you know, I think, we try to minimize and simplify things, but I think for some people that might work, and I'm fine with that. But I always try to start with one, and if I see benefit, I stick with that thing. If we feel like we need an extra, it's okay to add something else and see what happens, but in a more systemic way, as opposed to kind of starting everything at once and not knowing what's working, what's not working.
And there are a few other questions, as I mentioned, about the diet, and I'll lump them together. Is dairy yogurt inflammatory? Are non-dairy yogurts effective? And also, is there any research on keto diet and risk of IBD, since it does not sound clean according to your slides?
So I'm not claiming there are, being, you know, okay, let me put it that way. I'm a strong fan of Mediterranean diet, and it could be because it's how I was raised and that's what I enjoy. And I think there are a lot of diets out there that can work for some people and not for others, and they can have some benefit but also some inconvenience. So I think the keto diet is um, favors a lot of there's less fiber in the keto diet that I would want it. Okay, so it really depends what you're trying to do. Are we trying to lose a few pounds and then maybe go back to our regular diet? Maybe, but I don't think it's worth the risk. I think it's important to find the diet that works for you within the parameters that we outline, meaning having a good amount of fiber, legumes, fruits, vegetables, protein from diverse origin, meaning not all red meat, having some fish, having some eggs, having what I call the good fat, like the olive oil, the salmon, the avocado. So, and have sugar in their natural state. So, have a piece of fruit every day. So, and again, and like I said, for patients with inflammatory bowel disease, in the form and shape that you tolerate. Um, whether you want to call it Mediterranean diet, a specific carbohydrate diet, etc. But some diets really lack in the amount of fiber. There was recent studies showing that 80% of Americans do not consume the recommended amount of fiber. And I showed you that these fiber are so important in nourishing a healthy gut microbiome and in producing these short chain fatty acid. And it's when we talk about westernized diet, what is changing for immigrants to this country, that suddenly they come from a country where there's a low incidence of IBD, they come to our country, and then their risk of IBD become the same as people who've been living here. The most rapid change is diet and lifestyle, right? So they might be coming from a country where they're more physically active, they have to walk to work, they spend time outdoors, and then people come to this country where we're more sedentary, where we're driving cars, we're watching long hours of TV, and the diet changes. And our diet is mainly made of, you know, um, you know, red meat, cheese, things that are yummy, but they're not very healthy for our gut. Overall, in terms of diet, is very important. Like I said, keep it pleasant. You want to choose the things that you enjoy. And yes, of course, you can have a cookie from time to time. And of course, you can have a juicy burger. I mean, just looking at the image of that burger, I felt like I wanted a burger. So you don't have to be a saint. But if 80% of the time we are giving the right nutrients for our body and for our microbiome, I think we're good. And then you want to, have a great piece of cake, chocolate cake from time to time, or a double cheeseburger from time to time, that's perfectly okay. It's all about what is our regular diet, what does our mainstay diet look like, and then we want it to look, diverse and rich in fiber and prebiotic food and some fermented food, like I said.
Yeah. So again, we are approaching 1 o'clock. So I know that people are probably going back to clinics to see the patients. So one of the things I can takeaways from today's talk, I next time we do webinar, maybe we can do it like doing jumping jacks or something, doing like squats or sit-ups while watching or presenting, just to get more physical activity. So again, really, Dr. Charabaty, I think we could probably keep you here for much longer to chat with you and ask you many questions. I have saved some of the questions and we'll try to email you some of the comments and answers in the follow-up emails. I like to really, on behalf of the Alliance for Education on Probiotics, I would like to thank Dr. Charabaty for sharing insights and expertise with us. I'd like to thank Exegi Pharma for funding this event, and again, for all of you for joining us. Just to let you know, the Exegi Pharma actually distributes and produces Visbiome. So I don't know whether this is correct to say, but you can connect with them and see if they can send you some samples or more information about the Visbiome. Also, I really hope that our presentation on probiotics and IBD has provided you with some valuable information that you can incorporate in your clinics. And I'd like to invite you to join us again on December 1st, when Dr. David Armstrong will explore the science behind how probiotics can be helpful in managing IBS. And you'll receive the link to register for the final session, along with the link for today's session, and again, previous 3 recorded sessions on your follow-up email. So as Dr. Charabaty mentioned, that the clinical guide to probiotic products is always available for you in print as a booklet, online, or through our mobile app. All data is same across all platforms. And again, visit AProBio website. Then you can have very quick access to the clinical guides. You can see the content you can share with your patients, and it's all non-branded, independently reviewed, and evidence-based. So I really like to remind you that we are here to support you. So we strongly encourage you to complete our post-event survey to provide your feedback on this session, and let us know what topics you would like to see us explore in the future. So thanks again for joining us, and this concludes our session.
Thank you, everyone. Have a great afternoon.